Good morning and welcome to the House of Commons Health and Social Care Select Committee. My name is Jeremy Hunt, the chair, and this morning's focus is looking at lifting the lockdown and what is the basis of the scientific advice the government is receiving about lifting the lockdown. And we're very honoured this morning to have two extremely important guests, Sir Patrick Vallance, the government's chief scientific advisor, and Dr. Jenny Harries, who is the Deputy Chief Medical Officer, both very familiar faces on our TV screens over the last couple of months. And I'm also welcoming to this morning's session as a guest, Greg Clark, who is the chair of the Science and Technology Select Committee. I'd like to start by thanking Sir Patrick and Dr. Harris, and through them thanking their teams, because we often thank NHS frontline staff for all the work they do, but I know your teams are working equally hard, equally long hours behind the scenes. So please pass on our thanks to all of them for the very, very important work that they're doing. Now, the government has specified 5 conditions that have to be met before the lockdown is lifted. And what we want to do this morning is to go through all 5 of those conditions to try and understand the science and the basis of your recommendations on all of them. So the first one I want to look at is the condition that the rate of new COVID infections must be falling to manageable levels. And Sir Patrick, I'd like to start with you, if I may. Last week, we heard that the current R rate is between 0.6 and 0.9. I'd like to ask you, what is your estimate of the R rate today? And what level does it need to fall to before this condition is met?
Thank you. And thanks also for your comments about the teams working behind this, which we much appreciated. The R, we think, is still between 0.6 and 0.9. It's difficult to get a very fine granular estimate of the R, and that's true in other countries as well. We will, I hope, get a better estimate once we can measure it more directly by measuring rates of infection in the community with large population-based surveys. So we think it's between 0.6 and 0.9. There is a little bit of regional variation in that number. And one of the reasons that it's quite difficult to get a more precise estimate is because of what are essentially 3 different routes of infection going on at the moment. In the community, where we think the R may be lower, in hospitals and in care homes, where there's obviously possibility of infections coming back out into the community. And those 3 different sources make a very precise estimate of R quite difficult. In answer to the question of where does it need to be, it needs to be below 1, because as long as it's below 1, that means that the epidemic is reducing. And then instead of talking about a doubling time, we're talking about a halving time of the epidemic. And obviously, the lower the R, the shorter the halving time. So if you want to get down to very low numbers very quickly, you have to have the R as low as possible. But anything below 1 will be a reducing epidemic. And so therefore, the question about what value it needs to be at is dependent on how quickly you want to get down to the total lowest number in the community that you think would be manageable for the NHS and for the society as a whole. And that's obviously a decision that politicians need to make.
Thank you. One of the things that would obviously slow the rate of new infections is if people who've had the disease have some kind of immunity. So I just wonder what your current judgment is about whether people who've had COVID have immunity and how long you think that immunity might last.
The evidence that is accumulating from around the world, and indeed from the UK as well, is that the vast majority of people who have had an infection get some form of antibody response. So that looks quite promising in terms of there being an antibody response. It's obviously mainly known from symptomatic cases. So there is a question about whether asymptomatic cases also get an antibody response, and I don't think we know that for sure yet. What we don't know is the degree of immune protection that provides. So everything suggests that you can get neutralizing antibodies, those antibodies which protect against the disease. You can theoretically get them, and people have isolated them. So you would expect some degree of protection from antibodies. We don't know that it provides absolute immunity, and it almost certainly doesn't. It'll provide some degree of protection. And the other thing that we don't know is whether it's still possible to carry the virus even if you've got antibodies. So that is more about whether you could still be infectious to somebody else rather than whether you are protected against it. So I would say that the situation at the moment is that an antibody response is likely in most people. It's likely to provide some form of immune protection, but how much we don't know. And experience from other coronaviruses suggests it may last for 1, 2, 3 years, but not for many, many years.
Okay, it sounds like there is still, though, a degree of uncertainty as to whether an antibody leads to an immune response. And I just wondered, back on the 13th of March, you said the aim was to build up some kind of herd immunity where lots of people in the country had the virus so that they couldn't catch it again. When you said that, which was nearly 2 months ago, what was your evidence then for the existence of this kind of immunity?
Well, I should be clear about what I was trying to say, and if I didn't say this clearly enough, then I apologize. But what I was trying to say was that in the absence of a therapeutic, the way in which you can stop a community becoming susceptible to this is through immunity. And immunity can be obtained either by vaccination, or it can be obtained by people who've had the infection. And we don't know, as I said, exactly what degree of protection you get from natural infection, and we don't yet have a vaccine. The second thing to say is that obviously the higher the proportion of people in the community with immunity, the easier it is to control the disease, and ultimately the easier it is to release measures, so that vaccination becomes an important part of how you end up with protection, assuming you can get a decent immune response with vaccines, which we also don't know yet, but you'd expect there to be some degree of immunity. So I think expectation is that antibody responses will correlate with immunity to some degree, maybe very high, may not be so high, and that some degree of protection, whether it's to reduce the severity of the disease or to reduce the overall effect of the disease, I think, and the ability to catch the disease, I think we've still got some work to do to find out about that.
Thank you. You said something else which was very striking in that interview on the 13th of March. You said that we should be prepared to change our minds as the evidence changes. And we obviously know an awful lot more now than we knew then. I just wondered, if we were in an identical situation now as we were right at the beginning of March, would you still advise that it was wrong, it would be wrong to lock down the country at that stage, nearly 3 weeks earlier than we actually did, and that it would be right to go ahead with events like the Cheltenham Festival or the Liverpool Champions League match?
Well, I will restate what I said then, that I think this is a new virus. We don't know about it. It's something that nobody had ever seen before, and therefore inevitably we're learning as we go along. And as we learn, we will become more informed about which decisions we should take, and that's going to continue to be the case. And I'd remind you that we're still quite early in this epidemic, actually. I mean, although most countries are getting on top of the first peak in some ways, it doesn't mean the whole thing's gone away. So there's an awful lot still to learn. In terms of what would I do in retrospect if we knew then what we know now, I think that's something for the future to look at, and certainly there will be times when evidence didn't allow decisions to be made that you could make now, and there'll be times at which you look back and say that something might have been done differently. I've got no doubt about that. I think in terms of the timing at which we took our intervention, and I think the CMO was clear about this when he spoke recently, when you look at everything that happened, the speed at which it happened, maybe days either way would have made a difference. But I think it's difficult to look back and say 3 weeks was an obvious point to do it. I don't think that was clear. I don't think it's clear now. The other thing I would say, which is really quite important to understand, I think, is that we now, with the investment that we made in genomics of the virus quite early on, where we've been able to sequence thousands and thousands of viral genomes, that allows tracking of the provenance of different outbreaks. And one of the things that it looks like very clearly is that early in March, the UK got many different imports of virus from many different places. And those places were particularly from European countries with outbreaks. And so we see a big influx of cases, probably from Italy and Spain, looking at the genomics of the virus in early March, seeded right the way across the country. And so whether that was people returning from half term, whether it's business travellers or not, we don't know. But a lot of the cases in the UK didn't come from China and didn't come from the places you might have expected. They actually came from European imports and the high level of travel into the UK around that time.
Thank you. I mean, the reason I asked that question is not because of the benefit of hindsight, because we all benefit from that. It's just that if you're saying now that it's wrong to lift the lockdown if it brings the R above 1, it's just curious that before you were saying it would be wrong to introduce the lockdown when the R was between 2 and 3. And I just wondered how you would address the change in that advice.
Yeah, I think when the virus first appears, its natural rate of progression of R will be something close to 3, we now know. And of course, if you've got very small numbers that you can control with contact tracing, then you can tolerate an R that's a bit higher because you're managing it through contact tracing, and you can get on top of that very quickly and bring that under control. I think where we are now is that we know we've got a relatively large number of people who are infected with the virus, and we haven't yet got that number down to a manageable number to totally control with contact tracing and isolation. It's important that we have that as part of the plan going forward, and that will allow you to lift the distancing measures as you go through that phase. But it's really about the volume of number of infections we have in the country. And I think it is clear that there was a very rapid escalation of numbers in March, partly for the reasons I've just described, and that the doubling time was suddenly became very much quicker. And I think that was an important part of why it was important to start the lockdown.
Thank you. And just a final question from me. The government says that it always follows the scientific advice. Can you understand, as the person who chairs SAGE, why, if it says that it takes its decisions based on the scientific advice, it's absolutely essential that SAGE's advice to the government is published so that we can have some kind of scrutiny of government decisions? Well,
throughout my career, I've been a strong advocate of transparency and openness in science as a key measure. And I've on the public record in a number of different forums, including when I worked for the pharmaceutical industry, to say that it's very important. So I absolutely believe in transparency and openness. As you are aware, we have published some of the papers of SAGE and we'll continue to publish them. Some more have come out this morning. I want the team to get into a regular rhythm of publishing those papers. Those are the inputs to SAGE, and it's important that other scientists can see the input to SAGE, although most of that data is available to anyone to look at anyway, because a lot of it's public domain information. What is not a decision for me, but is an important one, is the output from SAGE to ministers. And you, of course, will be very well aware as Secretary of State that there's information that politicians need to see in order to make decisions that they need to receive in confidence and be allowed to have some time to make those decisions. And those decisions then, once they're made, then of course it's reasonable that the science behind that is something that people can look at. But I think it's not my business to be releasing the information to the public before ministers have seen it. My job in this case is to make sure that the ministers get the advice that they need in order to make decisions. And it's important also to recognise decisions are made on all sorts of different grounds, of which science is a key input, but it's not the decision maker. SAGE does not make decisions. SAGE gives advice. It's an advisory body, and ministers, of course, have to make decisions.
Understood. I think just in this case, the difference is the government is very, very clear that it is following scientific advice. That is the basis of every decision it takes. And that is different to the ordinary decisions that are taken by politicians. And so it's very difficult to understand or scrutinise what they're doing unless you can actually see what that advice is. I'd like to bring in Greg Clark next, if I may.
Thank you, Jeremy, and thank you, Sir Patrick, for appearing. Can I start by putting on record our gratitude for you publishing the names of the members of SAGE? It was something that my select committee called for, and I think it's justified this step, because actually what it reveals, as I expected, was that the strength of science that we have in Britain is very well represented. So would it not be worth continuing with that policy of openness and making sure that we publish the papers that SAGE considers in a timely way? It is, I think, the middle of March was the last time that the scientific papers were published. I think you've said that some have been published this morning. Will they be published more frequently in future?
Well, yes, I hope so. And that's definitely what I would like to see happen, that we have a regular rhythm of publishing papers. I think we need to get them out as quickly as we can. I'm sure you'll appreciate that the Government Office of Science is actually a rather small organisation, and they're working flat out and trying to get papers published and make sure that those have been appropriately cleared. But we will do that on a regular basis, and I'm very keen to get the papers out as soon as we can, with quite a large number having been released this morning. And as I say, I want to get into a much more regular rhythm of getting those papers out.
How regular do you expect it to be? Weekly? Every time?
I don't know exactly how, but it's not. It shouldn't be a month. I mean, it should be shorter than a month, and we should try and get them out on a regular day, as every couple of weeks or something, if we can. But I can't commit to being absolutely sure when that will be, because there's a lot of papers. Not all of the papers are ours, by which I mean some of the papers are papers produced by academics that they would wish to put into the public domain in the usual way through scientific peer review and publication. And the timing of when those go into the public domain is in their hands, not ours. But we are trying to get as many of the papers out as we can, as quickly as we can after we've received them.
I understand. You and Professor Whitty have been very clear that SAGE gives scientific advice, but policy decisions are separate, and they are for ministers to make. But the government has maintained, I'm sure accurately, that it's followed scientific advice in policy decisions. So in terms of being able to scrutinise that, is it not important that the advice, the scientific advice that's given to government is available for the purpose of corroborating statements that the scientific advice is being followed, not necessarily before or at the same time that it's given to ministers, to take your earlier point, but surely shortly afterwards, a summary of the scientific advice ought to be made available, so it's possible to discern whether the policy decisions that have been taken are indeed drawing on the scientific advice, and that there isn't a danger of eliding scientific advice and policy decisions.
It's probably worth just taking a step back and saying how SAGE has operated in the 11 or so years since it first started, which is that it was set up, it's obviously a subcommittee of Cobra, reports into Cobra, and it was set up in a way that the minutes are published after an event is finished, and that's how it's historically worked. What is obviously different in this situation is we don't know when this is going to end, and so the question is, what is the right speed after an event to publish the minutes. And I think that is a very important question. It's obviously one that ministers would need to take a view on as to whether they were happy for advice that's been given to them to be in the public domain. And what we're doing at the moment is publishing the input to SAGE. It's also worth reflecting that there are other times when science advice is given, and if you go back before SAGE was formed, it's actually very difficult to know what the science advice that was given then, because it's often not published at all in terms of what was there. So I think we're in a better position than the past, but I completely accept that with an ongoing situation like this, it's very important that the science advice is known, and the science advice should be open to scrutiny. And I think the timing of that, I don't think, should be at the end of the whole thing. That's clearly too far away. I think it's up to politicians to decide when they think they're happy to have the advice that's gone to them released into the public domain.
Why not SAGE have a view on that? Is it entirely down to ministers? If ministers are praying in aid to that advice, isn't there a joint interest in agreeing a time frame for publication?
Well, I'm sure there'll be, as I said at the outset, my view is transparency is rather helpful in this situation. My view is that the more that the science advice can be scrutinised by others, the better. And so therefore, I think SAGE will probably be of that view. We haven't asked that specific question, but I suspect more people on SAGE would be in favour of making sure that the science advice is available, certainly not waiting till the very end of this in order to release all of the information.
Thank you. And a final thing, just in terms of that advice, what we find in our committee is that in terms of measuring the impact of the coronavirus, the total number of deaths, excess deaths, as has been referred to, is perhaps a more relevant figure than those that can be directly attributed to the virus. In other words, indirect deaths as well. Is that your views, Patrick?
Well, I think there was an excellent piece written by David Spiegelhalter in The Guardian not long ago, which summed it up very well. He really got it right in terms of how one should look at this. I do think that excess deaths is a sort of integrated measure, because at the end of the day, that tells you the impact of the direct effect of the virus, the indirect effect on the NHS, and of course any effects of the lockdown measures themselves, which may also have adverse health consequences. And so I think it's right that excess deaths is probably the correct measure to look at as an integrated measure, but it'll take a while to see that. Of course, different countries aggregate that information in different ways, and so it's not easy to look across that at the moment.
So that being the case, as we know, and Professor Spiegelhalter has drawn attention to this, some of the deaths and the impact are going to be indirectly through the effect on the economy, and that we know a severe economic impact has its own consequences for public health. That being the case, it's surprising to me that the publication of the names of members of SAGE don't include a substantial component of eminent economic advisors, which, if this way of conceiving the impact is important, surely being able to assess the indirect impact of some of the measures to control the virus is important, just in the way as the medical impact is. Yes,
I think that's true, that is an important area. We have looked at that and are looking at that with Chief Statistician and others, looking at total excess deaths and trying to get a handle on that. And of course, at the moment, the economic side of this is integrated after the SAGE process. So it comes together later in the government process to take that into account. We have looked at whether we should now think about a subgroup of SAGE on economics. It's something that we're considering, but it's important that, I think it's important that SAGE can't become the integration of all knowledge in order to give government advice across every single aspect of this. At some point, the output of SAGE needs to be integrated with economic analysis from others. We do have an economist on Sage from the Treasury, and we do have other people who've got backgrounds in that, but we are not specifically looking at the economic impact that is being looked at elsewhere. What we will do is look at the mortality in different sectors and across total mortality to try to get a handle on that. But we have looked at whether we should have economists. What we do not think we should do, and we may be wrong and open to advice on this, but we do not think we should try and create some mega model of all the economics and all of the disease modelling and epidemiology altogether. We think that's going to just cause spurious accuracy. But we absolutely agree that economics is an important part of this and is being looked at very hard by other groups.
And perhaps just less on a disciplinary front, if we know that measures that affect the economy affect people's health and affect deaths, that must be weighed surely into the advice that Sage is giving to inform government decisions.
Well, it's being, at the moment, we are focusing on what we need to do in terms of controlling the epidemic itself and focusing most of the advice on the effects of changes on the epidemic. It is absolutely true that then there are the counter consequences of the lockdown that might have detrimental effects, and those are being estimated. But as I say, I think that's a role for government to integrate that information afterwards, not for Sage to try and come up with a single integrated answer. We have to concentrate on the disease outbreak itself as our primary focus at the moment. That may change in due course, but that is where Sage is focused at the moment, and others have an accountability to look at the other aspects.
Thank you. Dean Russell.
Thank you, Sir Patrick, for joining us today, and to your team and to Dr. Jenny as well. I've got two lines of questions, and I'll be relatively brief. The first one is just in terms of infection rates, and the second one is just in terms of use of masks. From an infectious perspective, how far are we in the science of understanding where people are most infectious? For example, is it a case that when they've got their symptoms in full flow, is that where they're most likely to infect somebody? And if not, and the reason why I ask is that is there a point here where, people who are perhaps less infectious at the start and at the end are going to have slightly less impact in terms of being locked down? And I'll follow up with my mask question afterwards.
We think that the most highly infectious time is a day or two before symptoms start and 2 or 3 days after symptoms start, and thereafter it tails off reasonably quickly in most people, so that by between 5 and 7 days afterwards people are much less infectious. So the peak time for viral shedding and infectivity is around the time of start of onset, but precedes it as well, which is one of the reasons that asymptomatic transmission is potentially an important feature of this illness.
So thank you for that. I just wanted to clarify before I ask my next question. So with regards masks, so I know that there's been a lot of debate around whether the public should wear masks, whether they're the PPE medical masks or whether they're just scarves around their mouths. I've been doing volunteering in my local Watford General Hospital, and I see a variation of people, some wearing masks and wearing not, from people that come in and volunteer. And I think the question really I've got is, with regards masks and covering one's face to stop infecting other people, is that something that you would say is worthwhile doing? And I have a very specific personal question to you, which is that which was given to me by a colleague of mine, which was that if you were in a supermarket that was full, everyone's still social distancing at 2 meters apart, and there are people in there perhaps coughing or perhaps not even showing that they've got coronavirus, would you feel more comfortable in a queue if everybody was wearing a mask versus if everybody wasn't?
Well, let me deal with the latter point of that first. If people are coughing, they should be at home self-isolating. Absolutely clear. They should not be out doing those sorts of activities. So that the key thing is self-isolation, and that will remain to be the key thing. the situation of masks, as you can tell by the number of eminent scientists who are very strongly in favour of one position or a completely opposite position, that the data and the evidence are not straightforward. So I'll tell you where SAGE got to in terms of its evidence, which has been given to ministers. We think that the evidence of masks preventing the spread of infection from one person to another is marginal but positive. So there is some evidence that it can do that. It looks like the major route of infection in this disease is probably droplet spread rather than true aerosol, but there may be some aerosol components as well. And masks may have a marginal positive effect in that situation, or face coverings of some sort might do. If I take the other situation, which is in healthcare workers, it's very clear in high risk situations with very high viral loads and potential for aerosolization through various procedures, then the role of masks is clear, the evidence is much stronger, and it's absolutely clear that those people should have masks. For most of us, the situation in outdoor environments is that the risk is really low, and the 2 meter distancing is based on a probability. And the evidence is, as far as you can get very firm evidence on this, that essentially a minute at 2 meters contact is about the same risk as 6 seconds at 1 meter. So that gives you some idea of why the 2 meters becomes important. And the risk at 1 meter is about 10 to 30 times higher than the risk at 2 meters. So the distancing is an important part of this. Where, therefore, masks may have a role is in situations where distancing is not possible. So there may be some cases where that simply isn't possible, where there may be undue crowding, but ideally they shouldn't be crowding. There may be times when wearing masks can therefore be beneficial to stop the spread. It's important that those coverings are worn properly. So in other words, they cover the nose and mouth. And it's important that people don't handle their face a lot, because there's a much, much higher risk in terms of transmission from hand to face, from touching things, so that the rather boring but rather important thing of washing hands remains absolutely critical in all of this. Face masks may have a role to decrease transmission in some situations that I've described.
Can I just clarify though, so I'm thinking more long term. So when the lockdown's lifted, we're going to have a lot more people out, and therefore the risks of them being in close proximity potentially higher. Even now, I go to supermarkets and people aren't always following the rules. So I just wonder whether that might taint the decision around whether everybody should wear masks, or whether potentially we should trial masks being used in one part of the country. Obviously, the tracing app, which was launched yesterday, which is great, is being trialled in the Isle of Wight, for example. Is there any sense of perhaps testing, perhaps post-lockdown or during the latter phases of lockdown, to have one area perhaps trialling masks to see whether it made a difference?
Well, the evidence, and this is where the evidence gets even weaker in a sense in terms of any positive effect. There's lots of theoretical reasons that we've laid out as to why masks might make a difference. In the trials that have been done, it's very difficult to see any significant effect. So they're quite difficult trials to do to get really accurate results, not least because the mask isn't the biggest component of why you get an outbreak in an area. And therefore it's unlikely that not impossible, but unlikely you get very clear results. So I think I'm not saying it shouldn't be done. There may be a good reason to do it, but I'm not sure it's a very easy thing to do. The decisions you're talking about, though, really they are decisions for politicians. We've given advice on what we think the evidence is around masks, and that is then for politicians to decide what to do. And you can see people making decisions around the world based on that, and Scotland has said what they're going to do based on the SAGE advice, and I think that's for ministers to decide how they want to take the SAGE advice. I will come back to those 2 points that I think really do need to be stressed. The first is that the role of proper surgical grade masks in healthcare settings health and care homes settings. The mask is really important that the PPE there is in the right place. Much less important in terms of being outside, walking around. And of course, this is a probability thing. So just to be as clear as I can, if somebody comes up and coughs directly in your face, of course, that is a risk. The probability, even at a short time, so if you're walking straight past somebody and you're 1.5 meters apart, you've got maybe a second or two when you're close. The probability of something happening in that time is relatively low. So these are fine judgments. These are judgments that I think politicians would have to make. And of course, they have implications for all sorts of things, including how we work as a society. And that's not for Sage to comment on.
Okay, thank you.
Thank you, Dean. I'd like to bring in James Murray and then Sarah Owen, James Davis, and finally on this section, Laura Trott.
Thank you, Chair. We've been told that the average R is currently around 0.6 to 0.9, which would mean the epidemic is overall shrinking as R is below 1. But you also explained, Sir Patrick, that R varies in different places and different contexts, and you suggested that it is higher in care homes. So I'd like to ask you, what is your current estimate of the level of R in care homes? And isn't it the case that the average R could be below 1, meeting the government's test, yet we still have a situation where infections are rising in care homes?
So, as I said at the beginning, I think there are 3 different sources of infection that we need to think about. Community spread, where I think the R is definitely down below 1 in nearly everywhere, if not everywhere across the UK. I think the sources of infection from into and out of care homes and the health service are critically important. It's very difficult to get an R value on care homes because they're spread around the country and they each have a different characteristic and the different risks. So we don't have an R. But what we do feel is that the care homes and the nosocomial spread, the spread in hospitals, are 2 parts of this epidemic that must be brought under control if we are to get control of the overall thing, because otherwise we get reseeding of cases into the community, and of course we get seeding of cases into those vulnerable populations who desperately need to be protected. So the control of infection in care homes and in hospitals, we think, is critical to the overall control of the epidemic.
Okay, so just to understand how that fits into the overall strategy, I mean, as we heard earlier, on the 13th of March, you set out the government's approach as being to try and reduce the peak, broaden the peak, not suppress it entirely, build up some kind of herd immunity, and at the same time protect those who are most vulnerable to it. So if that represents the government's approach, shouldn't they then at the very least ensure the virus is suppressed in care homes, where some of the most vulnerable people in society live, before lifting lockdown measures?
Well, again, just to reiterate, as I said at the beginning to Jeremy Hunt, my points about immunity were not actually about getting immunity through this route. My point has been clear from the outset that we need to suppress the peak. We need to keep the peak down, flat, below the level at which the NHS can cope, to protect the NHS and to make sure that we reduce deaths. So that's been the strategy. The care home point is absolutely right. I mean, we need to get on top of it in care homes, and we've been clear about that. And that's an operational matter. And it's quite important to distinguish between what Sage can and can't do. What Sage does is try to distill the scientific advice into a form that then others need to operationalize and take accountability for. So I think the questions that are being asked are rightly for DHSC rather than for Sage, actually, in terms of control of infection in care homes.
But you would agree that the outbreak in care homes does need to be suppressed?
Completely. I mean, I can't be clearer about that. It's a very important part of what needs to happen, control of the outbreak in care homes, and it's something that we've been clear about for a long time. That's an important part of this epidemic and needs to be controlled for sure. Not least, of course, for the people who are in care homes who are particularly vulnerable and particularly high risk of getting an infection. But it's also the transmission from workers inside and outside that I think remains an issue. I don't know. I mean, Jenny Harris may want to comment on this as well. I don't know.
Thank you. If I could. Sorry, can you hear me okay? Yes. Hello?
Yes, Jenny.
Sorry, thank you. Yes, thank you, Patrick. Yes, I would like to add to that. There is actually a subgroup of SAGE which is looking at some of the more scientific areas of interest in relation to care homes and the potential risks of disease transmission. But I think perhaps what James Murray was looking for was also how that does translate between the scientific advice and research and into the operational area. So I would agree, SAGE obviously provides the scientific advice, but there is we have a group of senior clinical leaders which CMO chairs frequently, and these are the sorts of issues which are discussed frequently. And I'm also actually personally linked into ministerial-led group which is overseeing work on care homes, and this particular issue of disease transmission risk in care homes is one where there have been a number of studies by Public Health England. It's quite early days, and I think one of the difficulties in trying to understand the key measures that can be taken are probably twofold. One is that these are very small studies and just giving early indications, but particularly in the elderly, perhaps the presentation of symptoms is not as clear-cut in some other members of the public. So we've heard earlier that you can have asymptomatic transmission right at the start of your illness, but actually in many elderly people in residential care homes there appears to be, if you like, a different sort of presentation, and it can be quite difficult then perhaps to understand the problem that's there. So clearly if an outbreak is evident, then Public Health England will always move in, do appropriate testing and provide appropriate public health advice. But I think one of the tricky things that we're dealing with here is to understand actually the step before that, and that is part of a very active programme of testing and scientific research now. So I think we will have more on that, but I wouldn't like the committee to think that there wasn't active scientific and clinical support to that area of work.
Indeed. I think we've just got 3 more brief questions on this section before we move on to the next section, when I want to ask you some questions, Dr. Harris, so please don't think we're neglecting you. Sarah Owen next, and then James Davis and Laura Trott.
Thank you, Chair. My question is to Sir Patrick. First of all, I'd like to extend my thanks to you and to your team for all the work that you're doing at this time. As has been mentioned already, the government defends its decision-making as being led by the science. My question, this part of the question can be answered with a simple yes or no. Has the scientific advice provided by SAGE to the government always been unanimously agreed by the many members, especially on advice given on herd immunity and when the UK went into lockdown?
Well, again, we give science advice and then ministers have to make their decisions. And all I can say is that the advice that we've given has been heard and has been taken by the government. Clearly, what we don't give advice on is absolutely precise policy decisions or absolute timings on things, so that those are decisions which ministers must take on the basis of the science. And I think the correct way of saying it is that the decisions are informed by science. They're not led by science, as you open the question.
Thank you, Sir Patrick. Forgive me, I'm just trying to understand how the government interpret the advice given by SAGE and what sort of advice and the format of the advice that is given by SAGE. So if, for example, there are different opinions within the members of SAGE, as you've already said, there are lots of different opinions about masks, for example, and the evidence around that. Does SAGE provide one considered option to government, or are different options and different advice laid out for the government to take a decision?
Well, we would lay out, what we don't do is just say there are 16 different views, take your pick, because that's not helpful. So what we try to do is to come down to what we think is a position or a range of positions, 2 or 3 options, to say these are the sorts of things you could consider. Here is the reason that we think that they are reasonable options, and here are the uncertainties that lie around those options, because nearly everything that we're talking about has quite wide uncertainty around it. And that uncertainty may be one that we can put some mathematical bounds around, so we can put some confidence intervals, or it may be genuine uncertainty. There are just not enough data in order to be able to make any sort of decision, or it may be a behavioural science approach where we haven't got the data at the moment and we have to give an informed view. So our output is very much in the form of options, it's in form of uncertainty, and it's in the form of what could be done and what the potential consequences might be, not here is the answer, get on and do this. I mean, that's not how it works.
Okay, so it would be more accurate to say that the government's decision making is being led by different scientific options, of which it has chosen one.
It's more accurate to say that the government's decisions are based on science informing them, with the best possible option as to what the uncertainties are around the information that's provided, and then obviously ministers need to make choices. But what we're definitely not doing, I just want to be clear about this, we're not laying out a menu of 15 options and say take your pick. We're trying to say the best possible consensus view on this is, which leads you to the following sorts of options that you might consider and the uncertainties that underlie those various pieces of advice.
Has SAGE presented the government with just one considered option ever, or is it always given the different options underneath it? Albeit a small range of options, it has provided the government with different options and scenarios.
I'm trying to think if there's ever where we've given a single option. I doubt we've ever gone and given a single option. We're more likely to have said, here are the range of things with the potential effect sizes, and these are the choices you could make at this point.
Thank you very much, Patrick.
James Davis.
Thank you, Chair. I have a question about the regional variation of COVID infection. 3 points, really. Firstly, do we need to see the R value and the incidence of COVID decreasing in all parts of the UK in order to lift the public health measures? Secondly, for those regions where there have been a low level of infection or we've been behind the curve, do people have anything to fear from the lifting of measures in terms of lower levels of immunity or any other factors? And finally, is there a role for a different release of public health measures in different parts of the UK? Thanks.
Thank you. The R is, as I said, potentially a bit variable across the country, but not huge variation. It's sort of, it might be 0.6 in London and 0.7 somewhere else. That sort of level, not huge change. The incidence will be different and the prevalence of infection. So we know that cities and densely populated places have a higher prevalence than rural places. So that is definitely the case. And an option that could be considered is to think about whether measures could be done locally versus nationally. That's an option that people could go for. There are pros and cons of that, and you can see it in other countries. People have looked at those, but those are possible scenarios that people could look at. There are some quite big complexities in terms of transport if you do that as well. I mean, once you go to a regional approach, you effectively are saying that you are going to demarcate regions very carefully, and you've got to control flow between regions. But that is a possibility. Your second question was around low levels and risk and about immunity. And again, I'll stress that what we don't know at the moment is immunity. What we know is antibody status. We're beginning to get some information around that. And the latest that I've seen suggests, and this is from probably just over 2 weeks ago, and it's reflecting 3 weeks before that, because that's roughly how long it takes you to get your antibodies, something like a 10% antibody positivity in London, and something much closer to 3 or 4% in other places, and it may be lower still in other places still. So I'd expect to see variation in that across the country, and we'll get more information as those studies go on. But I would not expect to see antibody levels much above mid-teens, I would think, but we will see.
So based on that, in other words, every region should perhaps be treated the same, because a 10 or 15% level of antibody prevalence is still very low, isn't it?
Yeah, I think in terms of vulnerability of population, there's nothing to suggest that you should treat different regions differently. There may be other reasons such as local prevalence, but as I said, that comes with complexities. But in terms of vulnerability of the population, you would need to get to higher levels than that to suggest that, you know, one place had a massively different protective environment to somewhere else from the population antibody, and we don't yet know exactly how much protection the antibody status gives you.
Thank you.
Thank you. Laura Trott.
Thank you, Chair. I want to ask a couple of questions about the role of children in spreading this disease. When the CMO gave an evidence session to us in early March, he said that closing schools was one of the lower impact measures that we could take. Now, all of the country would have seen the speculation in the weekend papers about reopening schools. And on the back of that, I've had lots of worried emails from parents about whether they're going to be forced to send their children back in. And also conversations with teachers who are very worried about the risk that they are exposing themselves to. So can you just clarify, please, Sir Patrick, what is the science behind how at risk children are, and does that vary by age? And then also, what is the role of children in spreading this disease to adults? And again, how does that vary by age? Thank you.
Yeah. Very clear that children are at much lower risk of clinical disease and severe disease. So for severe disease, the evidence is absolutely clear that they are at very much reduced risk, not zero risk, but very, very much reduced risk. And there's also reasonable evidence to suggest they're lower risk of getting symptomatic disease as well, or clinically evident disease. So in terms of the effect on children, it's much, much lower. The next two questions in a way are, do children become infected less? And there the evidence is less robust. And there is some evidence that children might be less susceptible to becoming infected. So, for example, I've seen data from other countries suggesting that they do have a lower incidence of infection itself and of potentially you can pick that up with antibody responses and so on. So maybe, but not strong. And our view from SAGE is that is low certainty. And then transmissibility. Are they sources of transmission? Again, the evidence is that they are unlikely to be higher than adults as a source of transmission, and maybe lower. And particularly young children may be lower risk of transmission, but the evidence again is not compelling, and you'd have to say it's low confidence in terms of that. So overall, children are fine. You know, they have less of a problem. Some, of course, do get a problem. Maybe they get infected a bit less. Maybe perhaps they reduce transmission, but we're absolutely not clear about that at the moment. So if you put all that together, and then you add one other thing, which is what is the role of children, not because of their infection or transmissibility, but their ability to contact across households, then what you see is that very young children actually are not such a big cause for transmission, because they don't have that household to household connection in quite the same way as older children do. So that's, I suspect, what underlies the decisions in lots of European countries to go for primary and younger age children first, because they're less likely to cause onward transmission, not for reasons of the biology, but for reasons of the contact and patterns of links between households. Older children, of course, are more likely to do that.
Understood, thank you. And just as a follow-up, is there more work going on in terms of to research what the transmissibility is? Because obviously this is a huge area, as you rightly point out, of uncertainty, as with so much with this virus. And obviously reopening schools when there is uncertainty around this is in many ways risky. So what work is going on to firm up the science in this area?
Well, the funding agencies across the UK, and very early on in this, I think in January, I can't remember exactly when, or maybe early February, we got the funding agencies together to say, look, get some rapid response funding in place to be able to answer questions. And the academic community, of course, has been applying for those grants and doing lots of work around that. So there's work that will be going on in the academic community across the world to try and answer these sorts of questions. And I saw some data that the Dutch health agencies shared with me recently about this as well. So there's a lot of work going on. Of course, any measure of lifting social distancing inevitably must come with a risk, because the reason they were put in place was to reduce the risk. So the moment you remove them, of course, you stand a chance of increasing risk. The very important thing going forward is to have very good surveillance systems to be able to pick up risk early. So nothing is going to be risk-free. Everything, as we go back to less social distancing, will carry a risk of there being an outbreak somewhere, or a few more cases, or in worst case scenario, R goes above 1. We need a very effective surveillance system to pick that up, which needs to be run nationally, but needs to have local granularity to be able to pick up things in and around regions that make sense.
Thank you.
Thank you very much indeed. This is the Health and Social Care Select Committee, and we are examining this morning the scientific evidence that's been given to the government as the basis of lifting the lockdown. And I want to move on to the second condition the government has laid. And if I could bring in Dr. Jenny Harries, who's been sitting very patiently for nearly an hour. And the second condition is that there needs to be a sustained fall in death rates. And at 9:30 this morning, the ONS published the latest all-cause mortality statistics that showed that for the week ending the 24th of April, the number of excess deaths was 11,500 higher than the 5-year average for that week, which was slightly lower than the previous week, but nonetheless significantly higher than you would normally get. I wanted to ask you, Dr. Harris, it's obviously too early to say which countries are doing best or worst on death rates, but the charts that you show us at those Downing Street briefings do have a pattern. And the pattern is that the UK is in a cluster with Italy, France, Spain, and Italy, but that Germany and South Korea, amongst others, seem to be doing a lot better than other countries when it comes to death rates. And I just wondered what your early analysis is of why that might be the case. Do we have Dr. Harris? Hello? I think I've got a technical hitch here. Do we have Dr. Harris on the line? Sir Patrick, can you hear me?
Yes, I've just been unmuted. I can see Jenny Harris. I think she must be muted.
I can hear you too.
Right. Dr. Harris, did you hear my question then?
I did. I heard it all. I was just
right.
unable to
Please fire away, and thank you for standing by, Sir Patrick.
So I think the really important message on death, apart from the sadness which of course accompanies them, is actually the fact that we will have to wait quite some time, I think, until the end of this pandemic to do robust comparisons, and even then it will be extremely difficult. One of the reasons for that, which I know has been repeated often for media questioning and in other environments, is because different countries collect their data in very different ways. You have highlighted that the UK has moved to a different pattern. So on the 29th of April, we have moved from publishing just the hospital data, death data, which is a very early and very robust way of giving an indication of the change in death rate, to moving to deaths in all environment where we know there has been a confirmed case of COVID. But of course, we now have a number of different ways of reporting deaths, and I think that can be appear to be quite confusing to the public. But I think the important thing here is sitting behind that is an endeavour, firstly, to be very transparent in what the position is. Secondly, to be clear that we are counting and looking, actively looking in areas where we have particular concerns. So, for example, that includes the care sector. And then thirdly, using all sorts of available information that we can to try and coherently put this pattern together, because along with the surveillance programs which Patrick has spoken about, we will perhaps find new clues to how we can better control the environment and make environments safer for people, particularly as we're coming through lockdown. I think your main point was about international comparisons, and I would go to the main point, which it is extremely difficult to compare between countries at the moment. We need to not just look at the numbers clearly, but at some sort of rate. So the obvious one would be an age standardized death rate per million population. Those are not the numbers that are routinely reported. And so, again, it is really quite difficult to do direct comparisons. I think it behoves us to look at this information and to check and to continue talking to public health and science colleagues in all of the different countries, particularly where there are significant differences, to ensure that we understand as best we can. But if I remember rightly, I think when the CMO came before the Health Select Committee last time, he highlighted a conversation he had with his German counterpart, trying to understand the differences in approach and the outcomes in the two different countries. And these remain unclear in some cases. So very important we look at death data, but I think also we need to be very careful about how we interpret it.
Well, I understand that caution, but this is a crisis where we're trying to learn as much as we can, as quickly as we can. And on the 26th of March, you said that community testing was not an appropriate intervention for the UK. Both South Korea and Germany, the two countries that are on those charts shown in Downing Street, appear to have had much lower death rates, carried on their community testing. So Patrick just told us that it's absolutely essential to know exactly where the virus is if we're going to track it. So do you still think it was right to stop community testing on the 12th of March rather than ramping it up rapidly, which we ultimately decided to do in April?
So perhaps just to clarify the statement, and apologies if I didn't do that at the time. The 12th of March was the period where we moved from the containment phase to delay. Up to the point of containment, along with many other countries, we had tried to vigorously contain with very active contact tracing, which is normal public health process, to contain cases and to contact trace each individual contact. Once you get very sustained community transmission, you are likely to see a rise in clinical cases, and you have more difficulty in trying to contain the virus. Excuse me. Therefore, at that point, there is an element which says the most important thing here is to manage clinical risk and to ensure that patients are managed safely and get the best care. And my comments at the time were that we were focusing our testing and tracing on those individuals. So at the time, we would have been doing outbreak control, for example, in care homes or in other high-risk environments such as prisons. So that contact tracing would have continued.
But my question was very specific, if I may, which is, do you still think it was not appropriate to test in the community? Because that's what they did in South Korea and Germany, and they do seem to have had much lower death rates than us. And we could have chosen then and at the beginning of early part of March to ramp up our testing as we actually did a month later. But we didn't. We stopped testing in the community, and therefore we stopped knowing where the virus actually was. And you were very clear that it would not have been appropriate to test in the community. You used the phrase, it's not an appropriate intervention. And I just want to check whether you still think that.
So I think the issue here is what capacity do we have to undertake testing, and where should that be prioritised? So in the unlikely event that a country has unending capacity to test, then I think we would continue. However, there is an issue around capacity, and it's not just the testing. I think, unfortunately, some of the conversations have ended with perhaps just thinking about the testing. It's the action that goes with it. So I think in the examples that you have given, there would be a large component, not just of doing the test, because that perhaps in itself doesn't lead to a change in outcome, but actually the associated actions. So in Germany, there was I think follow-on contact tracing, but there were also a large number of very different population groups. So a number of young people coming back from Germany. So the population comparison is different. In South Korea, they had very focused outbreaks, which in fact would have been followed through, I think, in the same way in the UK, because they were identifiable local hot areas, if you like, rather than sustained community transmission right across the country. So I think to answer your question, if we had unlimited capacity and the ongoing support beyond that, then we perhaps would choose a slightly different approach, but with the resources that we had. And I mean that in a broad sense, because many of the specialists and expertise that you need to carry out additional contact tracing will also be supporting the other changes that have been very successful. For example, ramping up NHS capacity. So there are clinicians working on the interface between public health and the NHS, and it's appropriate that that capacity is maximised to save lives, I think, as well as considering the spread of disease.
I'm sorry to press you on this, but South Korea had the virus worse than us. They're closer to China. They had a super spreader in a religious cult. Germany is closer to Italy, and they got the virus before us, but they carried on community testing. And the other thing is that just your comment just now about testing, when you were asked at one of the Downing Street press conferences about the WHO advice to test, you said the clue for the WHO is in its title. It's a World Health Organization, very much suggesting that advice to test didn't apply to high-income countries with developed healthcare systems. And I just want to understand if you still have that view.
So I would like to just clarify my position on that. I do think the test mantra, if you like, from the WHO was very much at a time when a number of countries were not actually testing at all. It was entirely appropriate to encourage the whole world to be testing, because unless you are testing, you wouldn't know whether you had any cases. And so the comments that I made were based very much to try and reflect that. That doesn't mean to say that I think more developed countries with more developed health systems shouldn't be testing, and indeed we did continue to do so. But there is a balance point in this with resources that you have available, and I use that in its broadest sense. This is very much about specialists to follow through with testing, that you need to prioritize that. And I think at the time that we did that, we had to balance our resources across testing in other areas. This issue about countries, so we refer to Germany a lot, but it is interesting that just on the testing alone, I think, and I'm happy to be corrected if not, but I think the broad number of tests carried out in Germany is broadly the same as the number of tests carried out in Italy. So testing per se doesn't have a direct causative link, and so it is the follow-on activity from that. And I think what we're identifying here is contact tracing, and there is a resource component to that and a prioritisation component which needs to be considered.
I'll ask you, did you advise the government on the 12th of March when we stopped community testing and contact tracing that you didn't want to do that? You understood why it had to be focused on hospitals, but really we should be increasing our testing capacity as soon as we can so that we can carry on testing in the community. Was that your advice?
So I wouldn't have made that advice personally, so just as a preface for this, but I think it was recognised within the plan for moving from containment to delay and mitigation, that as we moved into the delay phase, the prioritisation of approach would not necessarily be to be testing in all cases in the community, but to be focusing on that where it could have the most effect. But I think we have always recognised that there should be active testing within an appropriate framework, and of course there is a very large programme of testing available now, and of course it comes back to the earlier conversations which Patrick has made, which is different elements of testing are for different interventions, and it's important. So some for surveillance, which is absolutely critical. We've just been talking about understanding transmission, some for actual clinical management, some for ensuring staff can go back to work, for example. So I think we have always had a very active approach to increasing testing. And I think we do recognise and have always recognised that there may be a point where the prevalence of disease is lower, as we're coming to now, and I'm sure everybody's aware of the Isle of Wight test now, where when the prevalence of disease is under control, then that element of testing and contact tracing becomes a very significant part again.
Taiwan, next, please.
Thank you, Chair, and thank you, Dr. Harris. I've just got two questions. One is on migrants and the other is on certification of death certificates. So my first question, the hostile environment has meant that migrants feel uncomfortable using public health services, including the NHS. Now, in Professor Whitty's last statement at this committee in March, he stated that migrants being treated for coronavirus would not have to pay, nor would it be an impediment to their treatment. Have these rules been relaxed, and is cost still a barrier for these communities?
So clearly, the direct translation into policy of that is perhaps not something which CMO or I would be directly involved with, but it was a point which was actively considered. As far as I'm aware, it is still the case, and it was absolutely recognised that both for supporting the individuals themselves, but also for managing disease risk in the country, so the whole population risk, these were really important elements that we didn't want any barriers in place which would prevent people seeking treatment and actively getting tested. So as far as I'm aware, all of those measures are still in place.
Thank you. I guess my next question is that a constituent of mine sadly passed away in one of my care homes. His death was recorded as suspected COVID-19, but he was never tested. How do we ensure that appropriate cause of death is recorded on a death certificate? And if COVID-19 is suspected, there is sufficient number of test kits made available to coroners?
So I'll take that in two different parts. So just on the actual act of certification, if, for example, and very sadly in your case, a resident in a care home passed away and it was clear that they had symptoms of coronavirus or it was clinically suspected, then the doctor writing the death certificate will include that. It may be, for example, that an individual has a primary cause of death, which may be something unrelated. They would put the primary cause of death, but there's still an opportunity on the way the death certificate is written to say that COVID-19 was a suspected cause. It doesn't have to be proven. It has to be clinically considered to be a likely element contributing. And in fact, going back to my earlier points about death recording, it is exactly for that we are looking at data in different ways. So the ONS data will pick up individuals who have not necessarily had a confirmed laboratory test. So I think it gives us a much better understanding of where people perhaps have not been tested. And that may be for a number of reasons. So I think one is the testing capacity and capability. And of course, actually all care homes and residents now are provided with testing, and I know that can be quite difficult in practical terms. A number have reported getting the testing to them, and there have been a number of mobile units brought in. So if there is an outbreak in a care home, Public Health England will advise locally, and a mobile unit can now be brought in to support testing of residents and the staff, which is also important. But I think the other thing we need to be really mindful of in this disease is for residents in care homes, it is their home, they're near the end of their life, and sometimes they may not wish to have additional interventions. And that's another important element that I think we just need to consider.
Thank you. Oh, sorry, go ahead, Taiwo.
I understand that, but as you can imagine, the uncertainty on the death certificate can mean many families are left in distress as they're unsure of what the actual cause is for the death of their family member. So what support is being given in this situation where family members do want that clarification, and our test kits being provided to coroners to ensure that in these situations the deceased can be tested just to confirm what their cause of death is.
So sorry, and I'd misunderstood that. Are you talking about doing a test after death?
Yes.
In that case, so I was going to say, I think for if a family are concerned for a resident when they're alive, obviously then there are additional testing facilities available. There is advice for coroners, and I think that's very much something for the family to discuss individually. I think there is not provision particularly there, but we have additional capacity. So I think if a family is particularly concerned, there would be no reason why they shouldn't have that local discussion. There may be practical reasons why that could potentially be more difficult, just in terms of ensuring a result was valid. But I think that would be for an individual discussion.
Thank you, Dr. Harris.
Thank you very much. Just before I bring in Amy Callaghan, Dr. Harris, could you just move the microphone a little bit closer to your mouth? Not too close, but just a little bit closer. That'd be great. Thank you very much. Amy Callaghan.
Thank you, Chair. Sorry, it's my understanding that to know we have sustained and consistent falls in daily numbers of deaths, we need credible data. How credible is the data now in terms of the number of tests being conducted, the number of cases of COVID-19 and the number of deaths from COVID-19?
Yes, so I think we've always been very clear that the testing on the number of cases will not represent the totality of infections across the UK. And that has always been very clear. What we have done is tried to, where measurements are made, we try and provide those that are most robust as an indicator, but obviously to highlight any areas where there are caveats, if you like, in translating that through. So most of the early data, as I've highlighted with death data, is from hospital infection rates because it's much clearer what those are. And in terms of infection across the country, as Sir Patrick has pointed out, our real much stronger information will come particularly from ONS surveillance data, where families are recruited in based on a representative sample of the population, including on geographies as well. And what that will do is, short of absolutely testing everybody all at one point in time, which would not be practical across the country, what that should do is give a very good scientific estimate of infection rates across the country. The death rates really goes back to the points I was making earlier, and we have tried to, so ONS have altered or have published quite detailed guidance, which I would advise anybody to look at. There is more data, as we've noted, come out this morning, and that then gives quite a robust picture. There is always room for improvement, and I think one of the caveats with this data is just the practicalities about differences between registered deaths and the date of death. And so I know it can look quite complex, but in fact the data we've got now is trying to, in a very transparent way, show the deaths as best we can, including the excess deaths that we think potentially are taking place at this time. So I think our data, particularly on deaths now, is good. When we have the ONS surveillance data coming back, that will give a very good indication of prevalence across the country as well.
Thank you. Sorry, just to quickly pick up on another point, just as part of that initial question, how credible specifically is the data now in terms of the number of tests being carried out each day?
Sorry, in terms of numbers carried out each day. So tests are only counted once. I know there has been some concern about how that counting is being done, but I think John Newton, who's leading the collation of that work, highlighted in one of his interviews that a test either is counted when it goes out or when it comes back in. And of course, we've got a number of different testing pillars. And so there may be a lag in the time between when the test was taken and when it's reported, but it will only be reported once. And so from that perspective, they should be entirely reliable.
Thank you. Sarah Owen and then Laura Trott.
Thank you. I just wanted to ask a question around why we are seeing disproportionate deaths in BAME communities. Does the panel agree that this is likely to be about more than just biology, and that structural and socioeconomic inequalities are a major part of it? And if so, how will this be addressed in any lockdown exit plan?
Thank you, Sarah. It's a really important point, and I think increasingly as we get different data sets coming through. So I think there's a publication shortly from the obstetrics surveillance unit, for example, where there are potentially some signals, but I'm going to call them signals at the moment, because one of the problems that we do have is where we have done some, or not we, but different academics, different research groups have looked at data that they have. By the time you start taking out elements of particularly underlying disease prevalence, so things like we know chronic cardiac disease, for example, is a key contributor to poor outcomes from COVID. The same applies to diabetes. So when you start taking out the risk element from those conditions, which are frequently more prevalent in some Black and minority ethnic groups, it gets a very, very complex picture. When, as you've just highlighted, you then add in the complexity of the fact that perhaps cultural differences in the way people are living, or perhaps the fact that different groups will be more likely to be living or in socioeconomically deprived areas in some instances, it is a really, really complex picture. So I think what we're seeing are signals in some areas, but not all data sets are, when looked at in detail, are demonstrating very specific Black and minority ethnic disparities. So an example that I would give you is that there is a COVID a data set, COSIM, which is based on the hospital admissions, and I think this is where the signals were first picked up. That has been looked at in some detail and has not been able currently, I think, to detect a significant difference, but different signals are coming from different data sets. And I think the answer to this will come from the Public Health England work, which is looking not only at those characteristics, those variables which may be of importance alongside ethnicity, so the disease conditions as well, but is absolutely recognising that people will live in their own communities, and that socioeconomic element is also being considered. I also know that the Public Health England team working on that recognise how important it is to link with the minority groups while the work is ongoing, because I think actually people understanding the process and what that might mean for their community, whatever comes out at the other end, is equally important.
Thank you very much indeed. Laura Trott.
Thank you, Chair. Dr. Harris, you were very clear in your earlier answer to the Chair that infection numbers need to come down before contact tracing will work effectively. And we've talked about the R level extensively, but what is the number of new cases that we need to reach in order for contact tracing to be able to work?
So I think I was referring really from when we had a previously very high R rate. So at the start of the epidemic in the UK, I think it's reasonable to say I don't think we're putting a precise number on the number of infections, but as Sir Patrick has noted earlier, what we need to do is be really clear that we can consistently keep the R value down. And one of the reasons for trying the testing the test and trace mechanism app on the Isle of Wight at the moment is because it's clear that if we can maintain that R level down, it could be a useful adjunct to maintaining, to allowing a degree of lift in some of the measures while still managing to keep the infection under control. So I think the short answer is if the R value is down and can stay there, and we have trialled methods, tested methods that will work in practice, then we have opportunity to be moving in that direction reasonably soon.
There must be a range of number of cases you expect that you're able to deal with. So Professor Bantam last week at one of the press conferences said that the current infection rate, which was around 4,000 new cases, was too high. Is there not at least a range of infection numbers of cases that you think that a contact tracing program can deal with, if you think at the moment the level is too high?
So there have been some numbers looking at this, but I think we do need to understand how the app, for example, works, and then you almost have to translate the number backwards. So you can look at this in terms of how many contacts an average person might have, and these are the sorts of things that will need testing, I think, from the app work. And obviously the number of people that you need to use to contact trace effectively then relates backwards, if you like, to the number of cases. So it's not all starting from the number of cases, it's actually worked slightly the other way as well, which is what is the capacity to manage the contact tracing effectively and ensure we keep the R number down. So there are numbers which can contribute to this. As I say, if you look at the number of individuals related to each symptomatic case, then you can work out how many symptomatic cases you can manage within your contact tracing system. But I think we need a little bit more information as well from the work that's ongoing now to test out the theory and practice.
So we're looking to, as I understand it, recruit 18,000 contact tracers by mid-May. Is there an estimate of the number of cases you believe that those 18,000 can deal with?
I don't have it to hand, I'm afraid, and my apologies for that, but there has been some calculations behind that, and it includes the number of, as I've pointed out, the individuals who are related to each case. So I'm very happy to provide any information separately, but I don't have that number to hand, I'm afraid.
That would be very helpful, thank you. And then just a final question from me. Previously, you've been clear that we had to stop contact tracing at the early stages of this pandemic because community transition got in place. Now, obviously, we are now looking to restart this contact tracing at a point in the future when the R rate is down below 1 and we feel the infection numbers are manageable. What will be different this time, which will stop the number of cases increasing exponentially again that didn't happen last time?
So we're at a different point on the epidemic curve. So when we moved from containment to delay, the trigger point there, if you like, is the recognition of sustained community transmission. And what that means is you have, for each case, it may have a first, second, third, fourth transmission, a generation. And when you have sustained community transmission, you're finding cases, third and fourth generation, where you can't identify the early phase of that chain. What it means is you have cases seeded right across the population, and as we've heard from Sir Patrick, the R rate at that time was 3. Now, what we have done, or rather what the public has done, by managing social distancing measures with very strong compliance, is to push that rate down and remove a lot of that transmission in the population. And then as we come out of it, we should be able to control and identify many of the cases as they come up. So it's very much about it gives us a degree of control to lift carefully. But I think as many scientific colleagues have mentioned, Sir Patrick, but also CMO previously, this has to be a very, very steady and slow approach with very careful observation of what happens. So I don't think we should, I wouldn't like to give the impression that we now have this will resolve everything. I think we have to be extremely careful, and we have to watch as we're doing these things to see how much change we have, how many cases arise.
Thank you.
Thank you. This is the Health and Social Care Select Committee, and we're looking this morning at the scientific advice that is being given to the government on lifting the lockdown, and we're talking to Dr. Jenny Harries and Sir Patrick Vallance. And we're going to move on now to the third of the 5 conditions, which is that any lifting of the lockdown should not risk a second peak of the virus. And I'd like to ask Sir Patrick, if I may, why this third condition was changed, because originally it was that we mustn't risk a second peak, and then that was changed to we mustn't risk a second peak that could overwhelm the NHS, which is quite a small but significant change. And it's a strange one, given that the fourth condition is itself that the NHS should always be able to cope. Could you tell us why that condition was changed?
I'm not sure that I can tell you why that condition was changed in that way. I can tell you that the second peak, though, is something that is very real, that you need to watch out for, and you can see it in other countries. I think if you go back to the stated position of the government from early on, which is to make sure the NHS is not overwhelmed, it seems to me that's probably just consistent with that. But clearly, what you'd like to do from a pure science perspective is, having got this under control, the test and track and tracing takes more of the heavy lifting than the social distancing measures, if you can get this down to the levels where you can operate that effectively. And that's what you'd really like to do, and keep the whole thing down through that, allowing you to remove some of the social distancing levels. But what, in any event, I think is important is not to get into a position where you get the R above 1 and get a second peak. And where you choose to set that level, I think is a political choice as to how many, where in the spectrum you choose to put your line.
Okay, thank you. So, I mean, it's very clear from the trial on the Isle of Wight that's being announced today that testing, tracking and tracing is going to be our new way of trying to keep the virus under control and keep the R level below 1. Can I just ask you, on the 28th of January, when SAGE was preparing those options that you said it prepares for government, I understand that you decided not to model what the death rates would be with a track and tracing model, because you decided we didn't have adequate testing capacity. And so ministers weren't given the track and trace option as a potential option going forward. Given that in the end it was a heroic effort, but in the end we did actually ramp up our testing to German levels in just 4 weeks, I just wonder why we didn't model at that meeting in January what would have happened to death rates if we'd gone for testing, tracking and tracing right at the outset?
I don't know that's correct. I can't remember off the top of my head. I mean, we absolutely, right from the first meeting and at multiple meetings throughout January and February, raised the point of testing capacity and the importance of testing. It was in the very first meeting on the 22nd, I think we raised it, and pretty much at every meeting thereafter we discussed testing and tracking. I think, I'm sorry, I just can't remember exactly which modelling was done at which stage. And on the 28th, that was very early on, I suspect we were looking at overall modelling based on Wuhan data at that point and trying to see what predicted from that.
Okay, well, thank you for that. Luke Evans wants to ask some questions on this one.
Thank you both. And this is my first set of questions to Sir Patrick. And I'd like to broaden it all the way back out, because on the 3rd of March, the plan was put in place, and there's a document on the government website about the initial plan of contain, delay, research and mitigate. Is that still the overarching plan, or is there something new as we try and move on to a second phase?
Sorry, somebody muted me.
Yeah.
Let me actually, to some extent, this answers Jeremy Hunt's point as well. At the early stages, this absolutely was about trying to contain all the cases that came into the country and trying to isolate them. So again, I'm not sure what modelling we did at that stage, but that was definitely the plan, to try and keep as many cases isolated and track their contacts. And of course, what happened was that was based around geographical imports from China as the way to think about it. What became clear, or has become clear in retrospect, as you can see, as said earlier on from some of the genomic data, is we had a massive influx of cases not from China, from all sorts of other places, partly because of the huge connectivity of the UK. And one of the things we did model very early was the number of outbreaks you were beginning to see depending on transport connections to China. So you could see the initial outbreak, but then of course, once it went beyond that to being a pandemic, then you didn't know where it was going to come from. And we got a very large number of cases coming in right the way across the country from multiple European sources, somewhere around late February and detected early March. The plan now, as we said, is to absolutely get this under control with social distancing measures, get the levels of new cases down to a manageable number, and to therefore try and take more of the heavy lifting with testing, tracking of contacts, and therefore allow some of the release of social distancing measures, but to do it in a way that's part of a system that can pick up early outbreaks. And that, as I've said earlier, is going to have to be a nationwide system, but also with enough regional and local granularity to be able to pick up, if you like, sort of small fires springing up around the place.
So that 4-stage plan, is that still the overarching plan? Is it rinse and repeat and put it back out? Or is there a new stage plan for later on if there was to be a second peak?
Well, we're definitely in mitigate now and coming down. If there was a second peak, then you'd have to go very hard on contain for as long as you possibly could to try and get that under control. But you need to introduce the mitigate measures and the delay measures quickly. But the idea is to try and avoid a second peak as far as you possibly could.
Well, I think hopefully that we don't ever get there, but it's useful to prepare for that. And I wonder, as the parameters have changed, we have now got 100,000 capacity testing. We've got partial staff immunity. We've got public immunity. But we also have things like possibility of lockdown fatigue. How does that change the modelling if there was to be a second wave? God forbid we never get there, but I think it would be remiss not to ever think about what might happen in that point. And so, again, does that mean we use the same planning, or actually does it significantly change because we're in a different position and have moved on from 8 weeks ago?
Well, it would change in terms of the ability at scale to do some of the things that you couldn't do at scale at the beginning.
Perfect. And from that, to feed into that second model, what sort of conversations are we having about the international data, in the international way in which they're releasing their lockdown? Can you talk us through, Austria are opening their hotels on the 29th, some of the schooling has gone back, Germany have had problems. Can you talk us through how you're gauging that data and how that feeds into government policy?
So there's a lot of work going on in a group set up to continuously scan all international comparisons at seeing what they're doing and what effect that's having. There's also a group at the Royal Society that's been set up to do that, which is going to feed in information to us. And we have regular conversations. So just last week was speaking to the Dutch science advisors about how they're thinking about it and why they're taking certain decisions that they're taking, and have had discussions with Italians, US, all sorts of countries around the world, Singapore and so on. And I'm on a regular call with international science advisors from about 20 or more countries, trying to understand what people are seeing, what effects they're having. And you can see, and this speaks again to the uncertainty of the science, and I think it's important to really reflect upon the fact that this is not a set of absolute science outcomes that you can say, oh, there's the answer without any doubt. And you've only got to look at two very scientifically advanced and sophisticated countries, Germany and Holland, to see they're taking quite different approaches to how they're even thinking about schools in terms of the years going back. So these are judgments which get based on the scientific information. They are not scientific certainties that allow you to make an absolute decision.
Now, I have one final question, and it's for both you and then Dr. Harries. You're both clinicians. Clinicians, it's built into you to be reflective learners. I know that from my side. And in my appraisals, the way you go through, you're told to look back at what you've done. In terms of that 4-stage plan that you had, the contain, delay, research and mitigate, in your reflection, is there anything you would have changed or done differently? And if so, carrying forward, if there is a second break, could you explain that? And that's also to Dr. Harries afterwards, the same question.
Well, I'm sure there are lots of things that looking back, you think, well, what have we done that differently? That's normal. And as you say, it's absolutely standard in clinical practice to think about where you may have made different choices at different times. So I'd be amazed if when we look back, we don't think, yep, we could have done something differently there. In terms of what we've seen now, I think that probably in the early phases, and I've said this before, I think if we'd managed to ramp testing capacity quicker, it would have been beneficial. And, for all sorts of reasons, that didn't happen. And I think it's clear you need lots of testing for this. But to echo what Jenny Harris has said, it's completely wrong to think of testing as the answer. It's just part of the system that you need to get right. The entire system needs to work properly, and you need to have that link to contact tracing and isolation and so on. So I think there's going to be plenty of time to look back and say, what worked, what didn't work, which things do we need to do differently. I think going forward, we are now, as an international scientific community, extremely well connected on this, and we're learning from each other. And what we will see is natural experiments taking place. As people choose slightly different options, we'll be able to monitor carefully what effect those slightly different options take. But with one quite important caveat, there are quite important sort of differences between societies, which means that effects will be different in different places. I mean, I don't think it's chance that two huge cosmopolitan, well-connected cities with multiple imports from all over the world, New York and London, got very hard hit. I mean, these are cities that have certain features in common and are different from some other places. So I think we shouldn't view that the thing that works in Iceland is necessarily going to work well in London or in the rest of the UK, or indeed certain things that you might want to operationalise in certain parts of the UK, you might be able to look at things a little bit differently as you go forward because of the differences in density of population and other factors which could be important.
Thank you. And if I could put that same question to Dr. Harries in the context of the 4 initial plan, both your reflections and your reflections going forward if we were to enter a second wave.
So I think the plan as it stood was sensible and logical, and I think it's we will, as Sir Patrick has said, we'll obviously have to look back, I think, and see and compare. Certainly it was based on good traditional public health practice. I think one of the things which I'm reflecting on, and I suspect most of the world will, we're in a very different world now. So our digital capacities, we're focusing on the app here, but we of course are not the only country, is one of the things that perhaps we haven't yet done, is linked up that or pre-thought through the digital progression and opportunity in some of our preparedness planning. So I think there will be, in addition to the points which Patrick has made, there may well be some opportunities there to think through how we can be prepared at an earlier stage for that. I mean, I think we have learnt from previous incidents and done probably very well on things like the speed at which we have put out rapid research proposals, the work on vaccines and treatments and research protocols and things. That I think, when I look back to perhaps on my experience in Ebola with the international work, seems to have gone quite much more coherently and rapidly. But I think perhaps we haven't factored in what opportunities there are for digital use, and that would be good for our planning going forward.
And just to pull on from what Dr. Vallance said and from what you just said then, we talked about the interconnectivity, New York, London. We're still getting flights in. I understand why that's the case. In hindsight, should we have cut out flights more so? And what about in the future of pandemics? Would that be something that we need to consider a more robust approach on terms of travel?
Should I start with that one? I mean, interestingly, of course, we are bound, or we signed up to the international health regulations, and there are pros and cons, which are not necessarily always obvious, I think, between managing influx and outflux of passengers, but also goods. And of course, if you shut travel routes in, you also shut in routes for various products which may be essential, not just for our populations, but I mean all around the world. At the moment, we have most people who are coming back into the UK back home, and they of course will immediately fall under social distancing regulations anyway. And where we had identified high risk areas, as in Wuhan, for example, people in the containment phase came back in and were underwent very strict quarantine. I think it's an international discussion that we need to consider. It can't just be a single-sided position. And Sir Patrick's point about understanding through the genomics work the seeding of cases across the UK, likely to be through Europe, which was of course not the focus, means I think again, I think you're right. I think it will be a very fruitful area to consider, but consider it in the totality of the risks as well as the benefits.
Yes, I think in terms of travel, what was very clear, and I think you can see this now in retrospect, is that the idea that you could control this by stopping travel from one place doesn't work, unless it's, of course, your only source of import. But when you look at the cases, and I think we've now in the UK sequenced 13,600 viral genomes, and you can see it. We got imports from all over the place. So quite early on, the advice that SAGE gave was that if you're going to do something on travel, you either need to be extremely draconian and stop all travel from all sorts of countries, or it's really not worth trying to do it to try and stop from one place, because you won't make it happen. So I think the answer is not, unless the country chose to do that, to go for stopping travel anywhere, but to do what Jenny has just said, which is to make sure that as people come back, you have appropriate systems to isolate, to test, and to make sure that they are following the same rules as the rest of the country.
Thank you. Paul Bristow, briefly on this section, and then we're going to move on to our final two conditions. Paul.
Thank you, Chair. Well, my question has slightly been answered, but I just wanted to just qualify that. Do you feel that there is a risk of a second peak of infection in the UK when we do see people coming, British nationals, dual nationals from other parts of the world, perhaps who haven't had their peak of the pandemic? I'm thinking, parts of Africa, Pakistan, India, Bangladesh. Obviously, dual nationals in those parts of the world will want to come home. And if their countries themselves haven't been through their peak, is there a risk of a second peak in this country as they come back to the UK?
We did a calculation a few weeks ago on the likely impact of imported cases at that point. I can't remember exactly when it was, say 3 weeks ago or so, in terms of the total number of cases in the UK. And at that point, when you took all of the travel and you took all of the numbers coming in, it would have been something under 0.5% of all the cases would have come in through imports. Now, clearly, that equation reverses when you get down to very low numbers in your own country and you have higher numbers elsewhere. And that's when you need to be vigilant on how you think about isolation and testing of cases coming in. But again, this is a pandemic. It means it's everywhere, and therefore cases can come from anywhere in the world. And it's not going to be easy to say there are some places that you've got to be absolutely sure you don't get people in for. We've got to be vigilant across the board and vigilant in terms of cases in the UK.
Okay, thank you very much.
Paul? Just in our final 10 minutes, we're going to look at the remaining two conditions the government has set for lifting the lockdown. The first is that the NHS should be able to cope, and the second is that we have adequate supply of tests and PPE. And I'm going to bring in on this one Dean, who's got a question, I think, on the NHS.
Thank you. I'll be very brief, as I know the time is tight. My question, when we talk about the NHS coping, obviously previously we've talked about ventilators and capacity in terms of the hospitals themselves. Obviously we've got the Nightingale now, so it's been a great success. But where I want to just double check that when we talk about coping, are we also taking into account the NHS staff, our most precious resource? Because my concern is that they have been working day and night for quite a while now, are exhausted. There's a lot of people who are off. A lot of people who will be suffering from anxiety and all sorts in the coming weeks and months. So when we talk about the capacity to cope, are we taking into account our brave NHS staff?
I think this is probably one for Jenny.
Shall I answer that one? Thank you.
The answer is yes, anyway.
Yes. Without avoiding the question at all, obviously the bulk of this work will sit within NHS England and their HR components, but I think Patrick and I, like many of our science and clinical colleagues, will have friends and family even on the front line, and absolutely understand that it's a very traumatic time. And I think sometimes medics themselves are quite surprised at how much it has affected them. There are clear support programs going in, I think not just through the NHS itself, but equally importantly, I think from colleagues. So some of the specialist organisations, where, for example, for intensive care, there are peer support elements which are also through that group. And of course, the government, I think, has looked at a number of areas which signal, I think, value to staff in their coming back. And a huge number. So I think we've had something like 27,000 nurses, more than 10,000 professionals come back onto the front line to support this, which is a huge opportunity and and huge gratitude, I think, from the nation that they have put themselves forward. What it has done, of course, is I think meant that with the public support for the social distancing measures and managing the flow through, with that additional capacity, that hopefully some of the really difficult stress will have been relieved, but clearly not removed. And I think your point is important. I know that NHS England recognise that there is a considerable way after this. Often the impact, you get on with your job until it stops, and it's the impact afterwards which is quite significant. So it's not an area that I'm directly involved with, but I am aware that there is recognition both of the impact now, but also of the likely longer term consideration that needs to be given in terms of support to staff.
Thank you. Rosie Cooper.
Thanks very much, Jeremy. My question, two parts to it. The first one is, when can we look forward to test results returning within 24 hours? And the second bit, as infection rates rage in the Northwest, can Professor Harries give us more of a clue of why the Liverpool Atletico Madrid match was allowed to go ahead? If Atletico Madrid weren't allowed to play at home, why did our government not protect our citizens? Were we just sacrifices to herd immunity? And who was responsible? Who is responsible for making those decisions?
Shall I start that one? So I think the first point was about test returns. I think the time period for the test returns coming back is decreasing all the time. The actual test itself will vary in how it's taken. So obviously, if a test is sent out and is being sent back, that will be a different testing capacity to a patient having a test in a hospital. So I can't give you a single figure because it will vary by the type of test and the way the test is being delivered and returned. But I am aware that those testing times are coming down all the time, and that obviously reflects the capacity. And I think also going back to the digital point, of course, many, whereas previously in an old-fashioned way we may have considered how we would get the test result to the patient. Obviously, many of these tests now, the transit time for the actual result is very quick, but it's very difficult to give a single answer because of the different testing streams. On your second point, I think we partially covered this earlier on, some of Sir Patrick's comments. It's difficult looking at taking a single event and then translating that through to perhaps a causal link to cases in an area. There is a whole science behind gatherings, which is one element to that. And then I think the other one was the point which Sir Patrick picked up earlier, which was about timing of interventions. And I think perhaps what hasn't come out from this conversation is the different series of interventions. I think people seem to think there was a lockdown moment, whereas in fact a series of interventions based on science were recommended. But as Sir Patrick has said, the genomics suggests that actually a large number of cases has seeded already from Europe quite early on. So I can't give you a specific answer, but whether or not that particular issue linked to the seeded cases, it's not possible to say. It's quite likely that there were cases here through those European regions where in fact I think the focus of attention was perhaps more towards China and some of the Southeast Asian countries.
Okay, Rosie, do you want to have a quick follow-up, and then I'm going to have to wrap up, I'm afraid, but Rosie, quickly.
What is being missed? It was clearly shown that Atletico Madrid were not allowed to play at home. Why were they allowed to play here? I'm not going on to the causal links, just that simple question. It wasn't safe there. Why was it safe here?
So I think, not trying to avoid the question, obviously it's not, as Sir Patrick has highlighted, the advice around gatherings and the scientific advice behind that will have been provided through SAGE's work to politicians. But the individual decision about whether a match would go ahead or not is not one that the CMO or SAGE would take.
Thank you. Now, two very brief final questions from James Murray and James Davis. James Murray first.
Thank you, Chair. Just a quick question about testing numbers, which we've seen a lot of recently about the target of 100,000, but we never saw a justification for the number of 100,000 and the strategy associated with it. So can you tell us very quickly, if possible, how many daily tests approximately might be needed for an effective community testing and contact tracing strategy?
So I think this goes back to the points I was making earlier, and I have offered to come back with some numbers separately, but I don't have them with me. But I think the 100,000 was in some ways, I think, an ambition to stretch our testing capacity, which I think we've acknowledged here overall is a positive thing. There were some calculations about the number of cases we would tests we would need, for example, for all of the clinical care patients who were in the hospitals. That was our priority, and then our key workers, our health and care workers at the start, and other key workers. But it's also recognised that part of the testing links back also to our understanding of the position of the country, the prevalence of disease in the country. And so I think it was a broad ambition. It wasn't my 100,000 test. So I think you would have to ask political colleagues that particular one, but certainly moving us forward.
Dr. Harries, I'm not asking you to justify the 100,000. I'm asking you how many you think would be needed for an effective community testing and contact tracing program to be established. Just roughly, what kind of number are we talking about?
I can't give that answer at the moment. It was the same point that came, I think it was Laura Trott asked earlier, because it relates to the prevalence of disease and then the capacity of contact tracers you have to continue the contact tracing, and the proportion and that in itself relates to the proportion of people who are using digital means as opposed to population means. So they are all linked. And we do know that on average, depending on local circumstances and populations, we would estimate somewhere around 20 to 30 contacts per case. But it does depend on how the app is used and people's actions when some of these cases start lifting. It is very much a tread very carefully and see. I think the 100,000 is it puts us in a very good place to start looking at that process. But the work on the Isle of Wight will start to signal some of those parameters, and that will give us some of the numbers that we need for this conversation.
Thank you. And a final brief one from James Davis.
Thank you, Chair. Just very quickly, how far are we from the widespread availability of antibody tests that are both sensitive and specific, whether ELISA or lateral flow, and how important is it that we have those in place?
Patrick, I'll perhaps start on that one. Sorry, Patrick, you go.
Okay. I can tell you, ELISAs, accurate ELISAs, I think we're there. You can see them, that they're already being used, and they'll be, they're laboratory-based tests. I think lateral flow is still more difficult. I wouldn't like to put a time on that. And the question, of course, is what you want to use them for. So using those sorts of tests for surveillance studies may be okay, because you don't actually need very, very high sensitivity and specificity. Like high specificity, you don't need such high sensitivity. But for if we get to the state where you can say, you've got antibodies, therefore you are protected, then you need to have highly accurate tests to be able to do that. And at the moment, that looks like ELISAs. No doubt there'll be simpler ways to do it in the future, but as of now, that's an ELISA test.
I'm going to have to come in here. Just before we wrap up, just a very final brief question from me to Sir Patrick, if I might. And it's just to push you a bit about the likelihood of a second wave. If we properly implement the test, track and trace programme that we're planning to do, and if the public comply with the social distancing recommendations that are made by the government, could you just give us some sense as, let me ask you, if I was asking for legal advice, on a percentage scale of 0 to 100%, are you in the sort of 70, 80% that we're going to have a second wave? In other words, it's pretty inevitable? Or are you in the 20-30% that if we do the test, track and trace, if we follow the social distancing guidelines, we should have a reasonable chance of avoiding a second wave? Could you just sort of give us some sense?
I think if we do test, track and tracing well, and we keep the social distancing measures at the right level, we should be able to avoid a second wave. And so I'm on the more optimistic side that you can, provided you do it. And then I want to add one caveat, which is winter is going to be extremely difficult when you also have flu circulating and you have all the other respiratory infections which get confused with this. So that's the one caveat to that.
But thank you, Minnie, for ending on an optimistic note. And thank you to you for your time this morning. Thank you to Dr. Harris for her time. Thank you to your teams. Thank you to my colleagues on the committee. That concludes this morning's session. Order, order.